So this patient's coming in for evaluation of a mobile lesion that's sitting on over top of her sort of left scapula. This is shifting nice underneath the skin and seems consistent more with a epidermal cyst than anything else. It's not a pilarcyst because it's not originated from a hair follicle, and the one you have to differentiate between is a lipoma. Lipomas, they tend to move much more drastically when you shift them, and this isn't sort of doing that specifically. So what we've done so far, we put some anesthesia underneath the bed, and then we've frozen along this line, or anesthetized along this line. You can sort of see it's raised up a little bit, and that doesn't hurt at all.
No.
No pain there. So keep in mind, this is not an infected field, so if she does feel something, we can always add extra anesthesia and sort of take care of that. That sometimes gets complicated if the field's infected. The other thing I tell residents when you're starting into a procedure like this, these areas are sometimes a little more difficult. When you talk about getting out a perfectly clean, it's a little bit more challenging in these areas. Almost certainly this is probably going to rupture and then we'll have to take it out piecemeal, but that'll be okay. So I like a number 15 blade, and again we talk about incision lines. So these are the Langer's lines. You'll see how this is bending horizontally, if you can appreciate that. It's not vertically. So we want to do a horizontal incision. Like that. The other thing you'll find with these two is oftentimes you have to go deeper than you'd think, and that's, as you're getting used to these procedures, it can seem fairly daunting when you're a resident doing this type of stuff. I would tell you in general, the slower you go, the better you'll do. It's not a race, so you don't have to worry about finishing within a certain amount of time. So I incise a little bit, and then this will let me know if I can't with these curved cries, if I can't open it up, then it's just showing me that I'm not past sort of the dermal layer, which is really strong, and it's not opening up as much as I'd like. So we just grab the scalpel back again, and then we go a little bit deeper on this. But you're certainly better rewarded for taking your time. Now if you rupture the capsule, again, it's not a big issue. It's nicer and sort of cleaner if we don't initially, in terms of trying to see if we can sort of explore around it and maintain its position best. And then ultimately I think the final removal becomes a little bit simpler if you're able to maintain the capsule. But don't be dissuaded at all. You'll see on all kinds of these videos, and you'll see them just in your own personal experience, that you'll rupture the cyst. It doesn't have any impact on how well these are taken out. And this patient was asking just beforehand about why these form in the first place, and unfortunately she's had a number of them, and the studies actually do show, for reasons we're not clear, that people who are predisposed to them tend to be recurrently predisposed. In these particular cases, recurrent at this particular site should be managed by the fact that we take the capsule out, and as long as we get the capsule out, then she shouldn't have a recurrence here, but she'll likely develop other ones just because that's in the nature of who she is and why that develops in the first place. So if you look up pathogenesis of specifically epidermal cysts, this is the one where they do feel there is some thought process as to why it happens. They think it's resulting from trauma. So when there's been trauma to the first layer of the skin, which is the epidermis, and for those who keep track of this type of stuff, that's a 5-layered structure. And when there's pressure within the epidermis and it's pushed down into the dermis is the 2-layered sort of strong layer of the skin that gives the skin all its strength, its tension. Then what you do is you initiate this change. You drive the epidermis down into the actual dermis, and that initiates some growth down at that level from epidermal cells, which is why these are called epidermal cysts. And you can still see while this is opening up a little bit, I'm still not quite where I want to be. And that's why, and you'll still see to this day, there's the misnomer as to whether these are just sebaceous cysts. They used to all be called sebaceous cysts because it was felt that this was derived from sebaceous tissue. They've realized now that that's not accurate, which is why these are called the pilarcysts, originate from the hair follicle, or the pilar cell. here originate from the epidermal cell. And you'll know once you get into the right layer. And you're okay, you're not feeling that? No pressure, nothing more? If you do, just let me know.
So far, so good.
That's good. When you start to consider the fact that it won't change the actual outcomes, sometimes they'll very quickly, they even do an ellipse of tissue right from the beginning, just to see if they can remove a bigger area and get the cyst out that way. And I wouldn't fault them for that. You can certainly do it. I do like maintaining planes and being a little bit cleaner. I think there's some value in that. This is something I oftentimes do too. Once I get into a right plane, I'll use, if you're using a Kelly's or a Criley, you can put that underneath the layer you're at, and then just open that up. Thereby you're protecting the underlying structures, but you're still getting where you want to get to. Still don't think we're quite there yet. You're okay?
Yeah.
So you can see at that end, this is now below the dermis. It's opening up much more. It's just a function of getting the rest of my stuff there. You can see this does get through the membrane, but it's certainly a more tedious process. But you can also, I'll do it a little bit now, you can choose to use sharp dissection. So I use scissors here to open this up a little bit more. But like anything else, there's pros and cons. So once I know where I'm at plane-wise, I don't mind using it. But obviously the downside being obviously cut through structures easier. So you can see there, you can appreciate that tissue type is different. That's capsule that's there. And you can see as I shift it, it wants to excrete sebum, so there's a weakness that's there already. And you're okay? You see, you're going to just excrete a little bit of sebum. This is all a form of keratin that's there. Spray some material. What I'm trying to do now is separate where it's adhesing to the underlying tissue without truly disrupting it. That's what I'm going to do on the other side. I'm just going to lift the edge. And using the scalpel, I'm just going to cut it away a little bit. feeling fine? Now what I'll do with this is, what I try to do is clamp the opening of the cyst. And just applying pressure, lifting it up. So that I can dissect away the tissues that are holding it in place. Some of this will be supportive connective tissue. I could get some fatty lipomatous tissue with this. But then you'll be able to appreciate that this here is just fatty tissue. And you can see that's all capsule in through here. You see this here, you can see that that's all the membrane behind it. So this is where that clamp the opening, that's all the cyst in behind it. Take a look inside, you can see that there's no sebaceous tissue there at all.
So this is not sebaceous cyst?
No, this is not a sebaceous cyst. This would be called a epidermal cyst. Used to be called sebaceous cysts. This is just some superficial membrane I'm taking out now. That probably existed with a punctum that was coming to the surface. Side, there's nothing that's there. So we're just going to suture that closed. Now suturing it closed, again, I don't fault anybody if you want to do an extra dermal suture here. Here I don't, because we actually took tissue out. If I had tissue out being from underneath it, if I had taken extra skin out, then I would add in some dermal sutures just for strength, but I've never had any issues with dehiscence. Dehiscence is the medical term when a suture line opens back up on itself or releases. So in this particular case, this is 4-O-proline. Now you could start from either side or the middle in this particular case. I don't think it'll matter because again, you have a very linear incision. And you could argue why not doing just a running subcuticular stitch. Again, we don't tend to do that when we do procedures only because if you had a problem, if this got secondarily infected for whatever reason, you'd be forced to open up the entire incision line, which would be less than ideal. So we've talked about distance between sutures, and usually 7 millimeters is the goal we're looking for. So you can see here, I can continue all the way down. I'll start from the other end too and bring it together. So you see how that lays flat. That's in general what you want. And when you're doing these throws, it's really Feeling fine?
Yeah.
We're almost done. So the key with these afterwards is we always tell patients from an aftercare perspective just to make sure they keep this area dry. Oddly enough, it's usually exposure to a water source which will drastically increase your infection potential, your infection rate. So you can still take showers and stuff of that nature, but I would certainly use a watertight bandage over top of this area if that was the case. See as I'm laying these down that it's sealing quite nicely, and this is the big difference. You know, I've even get into situations where if it's questionable, I think I'd always throw in a dermal suture. But the other thing you can do is, let's say as you're suturing it, you've made the decision not to, for better or for worse, and as you're suturing it closed, you're just getting a feel that there's too much tension on your sutures. Then you can always just, it's very simple, and don't ever think you're committed based on a decision you made earlier on in the process, that you can just cut those sutures out and then add in a dermal suture and then go from there. So if these weren't laying perfectly flat and I was finding that there was actually some tension to the tissue, then I might second guess and sort of say, you know, just on point of principle, I'm going to lay down a dermal suture, and you would not be faulted for that whatsoever. Here you see, I mean, I could have making the option here to just put one last suture in and just have 5, but this is probably part of the bias of just having superficial sutures. I'm going to lay in the 6th one in between just to make sure that it holds nicely. Now just clean the patient up and put a dressing on that, and we're good to go.
अच्छा, आज आप लोगों को मैं अपना दिखाऊंगा कि मास्क जो है जिसको मैं पहनता हूँ, जिस मास्क को मैं पहनता हूँ, ये वो मास्क है जिसको मैं पहनता हूँ डेली, और इसको मैं डेली इस मास्क को वेयर करता हूँ, और ये बहुत ही कमाल का मास्क है जी, ठीक है। और इसके अंदर बहुत ही मुफीद चीज़ें होती हैं, इससे डस्ट रुकती है, इससे बहुत कुछ रुकता है जी, इससे आप अपनी चीज़ें रोक सकते हैं, ठीक है। कोई भी डस्ट आती है आपके नाक को मिलती है डस्ट, तो आप इससे रोक सकते हैं। ये मेरा बहुत ही अच्छा मास्क है जी, ये बहुत ही अच्छे ब्रांड का मास्क है। इसका ब्रांड का मैं आपको नाम भी दिखा देता हूँ। ये है जिसके ब्रांड का नाम ये है जी इसके ब्रांड का नाम, ये आप लोग देख सकते हैं। अगर पता नहीं क्लियर नज़र आ रहा है नहीं आ रहा, तो ये बहुत ही कमाल का मास्क है, इसको आप इस्तेमाल करें, मास्क इस्तेमाल करना चाहिए। डस्ट रोकता है मास्क, ठीक है, और इससे बहुत ही नुकसानात से बंदा बच जाता है। ये बहुत ही अच्छा मास्क है जी, कमाल का मास्क है जी ये, ठीक है। और आप लोग इसको यूज़ करें, इस मास्क को इस्तेमाल करें। थैंक यू।